But I know that there's a lot of people who want to know various IVF lab add-ons. Are they worth it?
We always say if an embryologist froze it, that means it met the criteria for freezing and it's got a good chance of success.
I like that.
Trust that.
Can you sort of tell us a day in the life as an embryologist?
Our transfer didn't work and our next best one is a BB. So our percent chance is 20% lower this time, right? It's like, whoa, like definitely.
No, yeah.
I don't know where you read that. Like, absolutely not. Like,
no. Now on a scale of 1 to 10, how important is the embryology lab?
Welcome to Trying to Conceive with Dr. Sasha Hakman.
Good morning, Shaun. Thanks for joining me so early in the morning. Okay, so we're here at the American Society of Reproductive Medicine conference in San Antonio, Texas. And we're talking all about the embryology lab, which is probably the biggest part. I mean, it's at least equally as important as what the physicians are doing leading up to getting eggs and sperm in the lab. So hoping that you can run us through it all. But first, can you sort of tell us a day in the life as an embryologist?
Yes. I'm amazed so many patients trust us with what we do because the embryology lab is probably like this black box for most people because we're so hidden and it's just like, who is in there and what are they doing and do they know what they're doing? Like, are they in a good mood today? I don't know.
Right. It's true.
So if I were a patient and I didn't know IVF, I think the IVF lab would like be something that makes me feel a little bit nervous. But it's not a scary place. Like it's full of very normal people like me who know what they're doing and are very good at what they do. So at my clinic, Utah Fertility Center, there's 9 of us embryologists, including me.
Wow.
Yeah, we're
good team.
We're a good size. We're pretty busy.
Yeah.
So any given day, there's usually like 2 people that are out, just rotating days off. So there's I guess typically 7 of us that are in there. The day starts with we got to check the embryos that are already in culture from within the last 5 days. So the first thing we're going to check is fertilization checks from the retrievals from the day before. First thing in the morning, you want to see how many fertilize for each patient that we inseminated. And then from there, it's kind of dividing tasks. Everyone has their own system in different labs. Ours is we will assign different tasks to each embryologist so everyone knows what their expectation is for the day and which patient they're working on. So from there, everyone kind of starts splitting out into their different assignments. Usually egg retrievals are starting at that point, 7 a.m., 8 a.m. So 1 or 2 people are assigned to do the egg retrievals while other people are continuing on embryo checks, like day 5 checks for which embryos are ready to be biopsied for PGT. Then we've got frozen embryo transfers that are going on. So people are starting to thaw embryos for transfers. There's a lot that needs to be done throughout the day. And it's important to have a system. And it's something that everyone, I think, tries to figure out in each lab. And in ours, I think we've come up with a really good system. Like it really works. We're quite
amazing,
efficient at it. Yeah.
That's great. Now, how do you ensure quality control as an embryologist when you walk in the lab in the morning, making sure all the equipment is reliable, effective, and it's not going to cause any problems?
Quality control is very important. And it's something that I feel like you can drive yourself crazy with it because there's endless things that you can look at and hone in on. So first thing in the morning, you're going to go through a lot of checks to ensure all the equipment is up and running. There's, no alarms. All the temperatures are right where they should be. The 2 main things we're trying to control for in the IVF lab are temperature and pH. So everything
for the incubators or for everything?
Everything that the eggs and embryos touch, we want to be at body temperature, 37 degrees Celsius. So all the incubators are heated to that temperature. The surfaces of the hoods that we work on are heated. So when you put a dish on there, it stays warm at 37. So we're going through and we're checking all of those, all of our hood surfaces. A lot of our stuff is on alarm system now, which is really nice. And they're constantly monitoring temperature. So any fluctuation and we're getting called. Luckily, it'll kind of like lull you to sleep of, why do we have to check this all the time? Like everything stays within range, but it's you're trying to manage risk. You don't want any equipment failure. So
it's like flying a plane.
Yes. That's it. Yeah, we're going in and we're like doing all the checks to make sure everything's up and running, warm, and functioning.
Amazing. Now, what happens from your perspective? As the physician, what we're doing is we're stimulating ovaries, whether it's egg freezing or IVF. Then I go to retrieve the eggs, and I always basically explain to patients the way it works is the fluid we aspirate from the follicles ends up in a tube, which then gets poured into a dish that the embryologist is doing, and they're looking under the microscope counting the eggs. So from the moment that you're getting this tube full of fluid and you're pouring it into a dish, what are you doing from that point forward?
In that follicular fluid, we're looking for eggs, and it's helpful to see an image of what they look like. And it's kind of fun to show people that come back in the lab, okay, here's an egg. It's a moment of like, whoa, that's an egg. Like that's a human egg right there.
Yeah.
It's probably not what people guess they look like. I don't know. Because there's just one cell. I mean, it's a very big cell. You can see it with the naked eye. But they come surrounded by cumulus cells. So it's like a cloud of smaller cells that are around them. So you're looking for this, it looks like a transparent little cluster. And when you look at that under the microscope, then you'll see the bigger circle of the egg in there. So we're just going through and finding all of the eggs from all the tubes that you're giving us. Once the egg retrieval procedure is done, then we're going to move the patient's eggs into their culture dish and into the incubator, which...
Now, at this point, do you always strip?
Yeah, so each lab has different...
We should talk about what that is, actually.
Stripping, yeah. Each lab has different protocols on when they strip. Most labs will trim at time of egg retrieval because lots of times those cumulus masses can be pretty big and fluffy, and those cells are pretty sticky. And so just for ease of working with the eggs, most labs will trim off just the excess of those.
How do you do that?
Some people are really good with just the glass pipette tip. They can just slide it on the dish and it'll cut. And lots of people will use a needle. It works great. They're super sharp and just slide along the dish and you can just trim off some of the excess. Some labs will strip at time of ICSI, and stripping is where we're going to remove all of those cumulus cells. And we're doing that if the patient's doing ICSI, the intracytoplasmic sperm injection. Our lab protocols, we just strip at time of ICSI. I don't think anyone has any data on impact of time of stripping, and if it has a difference, makes a difference. Everyone has different ideas and theories about, well, maybe if you leave the cumulus complex on, then the eggs are still communicating with the cumulus cells and maybe more eggs will mature for you, versus other people think if you strip right away, then you know which ones are mature, and the ones that matured later typically don't do as well. And so there's nobody that fights over it. It's not like a point of contention. It's just each lab.
But I do think about that all the time. It's like, maybe if we just delay the stripping, then we could get more mature eggs that didn't mature. Mm-hmm. But yeah, it's interesting to hear the lab aspect of it.
Yeah, I've heard labs say that, the ones that strip right away, because they'll separate the ones that are mature versus are not mature. And at time of ICSI, they'll check the ones that weren't mature, and any ones that have kicked out that polar body and are mature, they'll inject them. But then they say they don't do as well.
Right.
I think the fertilization rate might be lower, but I think the blast rate is lower.
Right.
Which is interesting. You're still going to inject them. Like, you're still going to give everything a chance, but it's interesting.
That it's lower. Mm-hmm. Yeah, I know. Huge limitation. Mm-hmm. So now you've trimmed and or stripped the eggs, and you've been able to determine which ones are mature versus immature. Now, is there ever a setting in IVF that, and I do talk about this sometimes, where you don't trim or you don't strip at all?
Yes. Conventional insems.
Yes.
And conventional insems are where the andrology department will process the semen sample. isolate the sperm cells from the semen sample, and then just put them in media that makes them really happy. And each lab, different protocols, but essentially you're going to add a lot of sperm into the drops of media that the eggs are culturing in. And we want to leave those cumulus cells on because those are what help guide the sperm to the egg. They've got like that chemotaxis, and that's what the sperm find them and then get in there. So yeah, we don't strip those eggs.
So to anyone listening who doesn't understand what the chemotaxis is, like there are chemical signals that essentially help sperm come to the egg to fertilize it naturally. So now, do you guys tend to have a preference on conventional versus ICSI? Is it at the discretion? I would assume it's at the discretion of the physician and patient discussion, though I feel that conventional has almost fallen by the wayside.
Yeah.
So I haven't really seen a lot of practices that still do a lot of conventional.
Yeah, as far as I can tell, a lot of clinics are mostly ICSI. Some places are 100% ICSI. They're just like, they don't even do conventional at all. We're probably like high 90% ICSI.
Yeah.
We have a couple physicians that still like doing conventional. Do you want to know how the lab feels about it?
Yeah, I want to know how the lab feels about it.
Conventionals they're easy. They're so easy. And ICSI, because you're going to be stripping the eggs, and then you're going to be on the microscope with the micropipettes, hand selecting sperm, injecting them in the egg. So an ICSI probably takes on average like 45 minutes. If you have a lot of eggs, you might sit there for an hour and a half versus
per patient.
Yes.
Yeah. It's a long time.
Yeah. And I enjoy doing ICSI. I don't mind it, but it's doing that versus taking a pipette and drawing up some sperm and just dropping it into the drops and then checking that
so easy.
There's some good sperm there and that they're getting to the egg, and then you put it back in and you're done.
Yeah.
So that aspect, embryologists it's easy and it's simple and it's kind of satisfying. And there's cases where there's no male factor. And so some embryologists are like, why am I doing ICSI on this excellent sperm sample? And she has plenty of eggs, but I try not to. I trust our physicians.
Yeah.
And that they've talked to the patient and this is what they want to do.
Yeah.
And so, we do a lot of ICSI.
Yeah. And I think that from the physician perspective, the part that's always a little bit scary is, especially when you're dealing with unexplained infertility, what if they're that 5 to 15% with total fertilization failure? And what is your feeling on rescue ICSI, which is when you get no fertilization and then you guys go back the next morning, see that fertilization has essentially failed, and now you go to do ICSI the next day. How do you keep sperm overnight? Like, how does that all work?
Yes, we always, with conventionals, keep sperm overnight because it happens and it never feels good when you go in there to check and there's just one or two or none that have fertilized. And then we're going to be doing the rescue ICSI, like you said. So we still have the sperm, still have the eggs. So now we can do ICSI first thing in the morning, but now it's day 1 versus day 0. So the timing has shifted close to 24 hours later. And so the success rate is a lot lower, but it still works. And we've had success with it. But
amazing.
Yeah, that's the scary part of conventionals is you're relying on that biological process happening. And it's interesting that sometimes that happens. Like you can put plenty of sperm in there. We put sperm in and then we come back and check about 30 to 45 minutes later because sperm will be getting to the egg that fast. Like they start finding it's like ants to sugar,
Yeah.
And so we come back and check just to make sure does it look good? Are the cumulus cells like dispersing with the sperm and our sperm getting to the egg? If not, we'll add some more sperm. Like we want to make sure they're getting there. So if there is a failed fertilization, it's not because the concentration was too low.
Right.
But it happens.
Right.
And it's hard to give a patient an answer when they go, why? Like I don't sperm or the egg or both. I think we're finding out why you're not getting pregnant, though.
Right.
It gives you an answer.
That's the part I always have to remember as the doctor when there's a bad outcome. Sometimes some of us will take it so personal. Like, did I do something I could have done differently? And you go back to the chart and you overanalyze things. And then you remember these patients are coming here for a reason.
Yes.
They didn't conceive prior to this for a reason. There's something happening.
Yes.
Yeah.
And it's hard to say that to a patient when you have, some cycles that just don't go well. They don't get many blastocysts, or the quality's a bit lower, and they start getting frustrated. Like, well, what happened? And I don't ever say this to a patient, but if you only made beautiful blastocysts, you probably wouldn't be here. And we have to remind ourselves of that in the lab too. When you have weeks where it's like multiple patients aren't doing well, and the physicians start asking, like, does everything look okay in the lab? Like, yes, I promise we're checking everything. Temperatures are great. It's just we deal with infertile people, and like a lot of them struggle. Like, hopefully we're getting the best that we can from them. But yeah, that's a tough part.
It is tough. Now to backtrack with sperm processing. I know that you're on the embryology side, not so much on the andrology side, but as an embryologist, what is your view on Zymot? So microfluidic sperm processing, like how do you feel about it? Who's a good candidate when you're getting a sperm sample?
I think in theory, everyone is a good candidate if it really is delivering what they say, which is historically we centrifuge sperm. We use what's called a gradient. It's a fluid, but it has like these tiny microscopic beads in it, and that acts like a filter. So you layer the semen on top of that fluid, and then you centrifuge it to send the sperm through there. And then that's supposed to select for motile and good morphological sperm. But what people are finding is centrifuging sperm, or aggressively centrifuging them, could potentially cause DNA damage in the sperm. So then Zymot comes along and says, we have a solution where you don't have to centrifuge. You add semen to this little plastic dish cartridge, and then the sperm are able to swim through a filter into media, and then you just draw it off on the other side after like an hour of incubation. And so I guess, like in theory, everyone should benefit from that. You don't want to cause DNA damage on anyone, especially someone that maybe already has a lower quality sample. So we've made the switch at our clinic where we process all of our samples with Zymot. I don't think we've seen like a big difference in outcomes, but that's where I think it's tough, because it's hard to know which patient really benefited from it. Like, I'm sure there are other patients who were already borderline, not great sperm quality, or maybe already have a higher DNA fragmentation. And because we didn't centrifuge, maybe the outcome was better with that patient. But how do you know?
That's the biggest challenge in our field is we try to account for every single variable, but there's always confounding variables that are going to affect outcomes. And then you can't even compare within a patient cycle to cycle, because every cycle is a new set of eggs and sperm. And so even though it's the same patient, sometimes you have a different sample of eggs and sperm and you get a totally different outcome.
Yeah. So, how do you go back in time and try something different and see how it works? On those eggs, or
you can't.
Yeah, like doing transfers. You transfer the embryo one way. You can't go, okay, it didn't work. Let's transfer the same embryo. Like, every time it's different.
Yeah. I mean, one of my colleagues, and you probably know Dr. Richard Paulson, he's past president of the American Society of Reproductive Medicine. And he told me this line when I was going through a patient case with him that really stuck with me, where, I told him a lot of times patients are going to tell me that they want to change their medication protocol in preparation for an embryo transfer. And he always tells them, when my patients tell me, you're doing the same thing, why are you doing the same thing again when it didn't work? He's like, I'm not doing the same thing. I'm transferring a different embryo. So therefore, it is a completely different thing. And that really stuck with me, because even with subsequent IVF cycles or egg freezing cycles, whatever it is we're doing, it is a completely different sort of thing, because we're dealing with new tissue samples.
Yeah. Oh, that's interesting. That'd be hard as a patient. Like, That's true. Why would you do the same thing? Yeah.
But the reality is that the people who usually don't end up conceiving is from cessation of treatment for the most part. And so if they continue, and I'm not saying in every case you should be doing the same exact thing, but the reality is when it comes to embryo transfers, for the majority of cases where things are fairly straightforward, a single failed embryo transfer is nothing to get excited about, because at least I tell my patients, we need at least 2 to 3 chromosomally normal embryos before you're going to get to baby.
Yeah.
We hope the first one is successful, and more times than not, it will be. And that's why we have that 65% pregnancy rate, 65 to 70, depending on what studies you're quoting, depending on the lab. But you're also going to have a number of patients who are not going to be successful with the first embryo transfer and need a subsequent one. That's just our reality.
Yeah.
So,
and this gets into embryo grading, because if you started with the best graded embryo and that didn't work, the psychological impact that must have on the patient, like, wait, that was our best one. And we've had patients that when they do a transfer, they say second best quality. And I think it's that thought of, well, if this doesn't work the first time, I don't want to.
Interesting.
Yeah. It's an interesting psychological aspect. And I talked to a patient once where they had done a transfer. It was like an AA or an AB, and then their next best one was like a BB. So like a good graded embryo. You got to take embryo grading with a grain of salt. Like, don't lean on it too heavily. I was talking to a patient, and they said, well, our transfer didn't work, and our next best one is a BB, so our percent chance is 20% lower this time, right? It's like, whoa, like, definitely.
No, yeah.
I don't know where you read that. Like, absolutely not. Like,
no.
Probably just as good. Like,
okay, so I want to go through embryo grading in detail, but I do want to backtrack on ICSI a little bit.
Okay.
So when you're doing ICSI, which is you're hand selecting what is supposedly the best appearing sperm to you, and then injecting it directly into the cytoplasm of the egg. Now, this is still a very manual process, correct? So this relies heavily on the skill of an embryologist. Have you, maybe not in your current practice at all, but is there this thing where this person is not as skilled, this is why pregnancy outcomes are not as good, versus everyone has to go through this really rigorous training and get vetted, and everyone's sort of on the same playing field?
Yes. It's a very thorough training process, hands-on. It's so good to watch lots of different people do ICSI when you're training. You're going to pick up tips and tricks from everyone. Everyone's style is a little bit different, and you find what works for you. Like, since I started doing ICSI, I know there's not one right way to do it. It's, for some reason, the way your suction is, it works better when you use your right hand this way. Like, you got to figure out what works for you. And it's so important to be very honest in your IVF lab, to track KPIs, the key performance indicators, and to inform your embryologists how they're doing. And if you're really on top of your embryologist, everyone should be. You set thresholds. You have your kind of lower limit, the level at which everybody should, at least their fertilization rate should at least be here and above. And then you have there's a word for it, and I can't think what it is, but there's one that's like, if you're up here, like, you're killing it. And it's interesting to collect that data and then compare everyone, but it's so helpful too. So, like, in my lab, we recently, like, really put together a lot of our ICSI outcome data, and we have 2 embryologists that are insanely good at ICSI. Like, their number, it was like, we were looking at donor eggs just to control for egg quality, and they had like 500 eggs injected for their data set, and their fertilization rate was 90 and 91%, which is like you guys are really good.
Wow.
But that's a resource. Now, hey, let's come together. Let's talk about, like, why, like, what are your tips and tricks? What's your, like, keys to success with ICSI? We've got young embryologists that have been doing this for a year, and like they're doing fine, but how do you get them to 90%? And just being really honest about it with people, like, hey, like your rates are fine. I'm not saying you suck at this, but we've got Aaron over here who's doing 90%. Go watch Aaron. Like, let's get you up there. It's good for our labs, good for our outcomes, but it's good for you as an embryologist and like your career. Like, if you ever move somewhere, that's something a lab's going to ask you. Like, hey, what's your FERT rate when you do ICSI?
Yes. Now, do you find that there are physicians who request certain embryologists to do things?
Oh, not at my clinic. I think everyone has the trust of the physicians. Sometimes patients will request embryologists.
So how do the patients know the embryologist to request them?
It's been like the embryologist did their transfer 2 years ago, 3 years ago, and they got pregnant, and now they want Shelby again.
Okay.
One time I got requested to do someone's insemination, and it was like their friend had come through, and it was conventional. Their friend had done conventional. Like I did their conventional, which like there's almost zero skill to that, just adding sperm. So like, Shaun, we were successful. We want Shaun to do it. Like, okay. And everyone was giving me a hard time. Like, yeah, I'll do it. What? And their friend did conventional again. And it was like amazing outcome. Like it made me look good, but
that's amazing.
It was funny. Because like, I didn't do anything, guys. Yeah. You're going to want me to, you're going to want me to be honest.
Yeah. That's great. So, okay. So ICSI is still very manual. I think people don't realize too, that when you're working under the microscope, there's special microscopes, very special equipment like anti-vibration tables, which I don't even know how that works. I just know that I'm assuming that if there's anything that would move or shake, it just doesn't affect the process of you injecting the sperm.
Yeah. I mean, if you think about it, we're dealing with microscopic things and everything's, it's joysticks. So it's very much like playing a video game. You got joysticks and these knobs that you twist for suction. And it's hydraulic, so it's doing very fine movements.
Is the suction to hold the egg in place?
Yes, to hold the egg and then also to suck up the sperm and then to inject into the egg.
How do you choose a sperm? How are you looking at the sperm and saying, this is the one?
The head's a good place to start. You look at the shape of the head. It should be like a good, consistent oval shape. How does the tail come off? Does it come off crooked? Are there two tails? I like to kind of look at the way the sperm's moving. Some sperm will just swim in a circle, and nobody's like proven this, but there's I think there's two proteins that are involved with sperm motility. So I don't know, maybe one of those proteins are missing. There's a problem with the genetics, so I avoid those ones. Like,
so how are you? I mean, when they're swimming fast,
we slow them down.
Okay, so I was going to ask, because when you're looking at sperm for a semen analysis, for instance, I mean, the good ones, they've already escaped. You don't even know where they're at when you're dealing with millions of sperm.
Yeah.
So how are you able to really take a look at the motility and the morphology and determine that this is a good sperm that I want to select to then inject?
We put them into a thicker medium called PVP. And so when you put them in there, it slows them way down. So they're moving forward, but you can catch them and you can see what they're doing.
Amazing.
Yeah, it's a good hack. I don't know how else you could do it, because they can zip around.
Right.
Because we've taken them out of the seminal plasma, which is pretty thick, and just now they're just in this thin media. That's makes them really happy, and they're flying around.
Yeah, absolutely. So now, once you have injected sperm or done conventional fertilization, where you put sperm and egg in a dish, the incubation process would be next, correct? So I know that there are some IVF clinics that primarily use regular benchtop incubators. Some are only using time-lapse incubators. I mean, I have my feelings about which ones I prefer, but as an embryologist, do you feel like there's a really big difference?
With time-lapse?
With time-lapse and then taking the embryos out of their environment to take a look. Do you check on day 3, or do you just wait until day 5 to check on them? But then are you rechecking day 6 and day 7? And how much is that affecting embryo development? Yeah,
that's a good point. We were talking about quality control, and I think for lots of things, I tend to like to be a bit like reductionist with things, just so I can understand what is it exactly that we are doing, and like my role as a technical supervisor. What is it that we're trying to do in the IVF lab? Because there's so many things that we're doing with protocols and procedures and risk management and quality management. What am I really trying to do? And the conclusion I've come to is we're trying to not do anything negative for your sperm, eggs, and embryos. Current technology, I can't change the biology of the eggs or the sperm or the embryos. I can't change the genetics or the quality of the egg. Current technology, right?
Right.
So whatever a patient gives me for their eggs and their sperm, that's what I have to work with.
Right.
My job in the IVF lab is to make sure I provide the best environment possible so that their biology has the best chance at success. Which when I started coming to that conclusion, I was like, is that pessimistic? Like, we're not actually doing anything good. We're just trying to not do anything bad. That's important to understand.
Yeah.
I don't ever say that to a patient, but I can't make your eggs better. We're just going to try and get the best possible outcome. And so things like taking embryos out of the incubator, they are covered with oil. So it does give you, there's a time buffer in which the pH will start to shift. We have to get more like sciencey with that. The medium that they culture in requires gases to come in, CO2 to come in to maintain the right pH. And so these incubators have gas that are constantly fed into them. And that's another part of quality control and like making sure pH will drive you crazy. But, and then we cover them with oil to avoid evaporation. And then also the oil provides a buffer, like the gas moves through that oil, it saturates the oil. So when you take a dish out, the pH will start to rise on you, but you've got time because the oil's slowing it down. But yes, in theory, you take a dish out, you're gonna wanna move fairly swiftly because that pH can start to shift on you. Versus a time lapse, you put them in there and you leave them in there.
Right.
And you don't take them out until you're gonna do something like biopsy or freeze them.
Right.
We have one time lapse incubator. I think one of the nicest things about time lapse is you don't ever miss fertilization check.
Yeah.
Because there's a narrow window of time in which you can confirm that fertilization was successful when you see the two pronuclei show up. And it seems like some patients' eggs move faster through that. They go through syngamy sooner. And so without time lapse, you're taking a dish out first thing in the morning and you're checking all of them and you're seeing how many fertilized. And then you're separating the ones that didn't. And we still culture those ones where we didn't see fertilization. We'll check them again on day 5. And it happens a lot where you've got beautiful blastocysts in that non-fertilization. And then this becomes a debate in the industry. Like, okay, well, what do you do now? Because you don't know the fertilization status of those embryos. Are they normal?
Right.
Did they just move did you just miss it? Or is there something abnormal going on? Time lapse.
I think people don't even, and for anyone who doesn't even understand this part, when you're looking the next morning after ICSI or conventional and you're checking to see if the eggs are fertilized, you're looking for these 2 little circles inside the egg, which indicates that you have DNA from sperm and DNA from egg. And eventually those 2 circles will fuse together and disappear.
Yes. And I've always thought the circles look like Ritz crackers. They got like the little dots in them. Yeah, they look like Ritz crackers.
They kind of do. Exactly. Yeah, that's a really great description. So yes, and we continue to culture if it's a 0 PN, for instance. So you don't see those 2 circles that indicate that it normally fertilized, but we continue to culture those, and sometimes those embryos come back chromosomally normal, and we transfer them, and we have pretty much the same success rate. And it just could be that process happens sooner. It
could mean they're your best quality ones.
Right.
You don't know.
Right. Yeah. We actually did an analysis in our lab to compare 2 PN versus 0 PN. The euploid rate was the same. And then the pregnancy rates were about the same. I think it was like a 1% difference.
That's what I would anticipate.
Yeah.
I think they're normal. I think they're good.
Yeah.
And we're doing so much PGT that you're going to test them anyways. Like, why would you?
You might as well.
Yeah.
Right.
We include them like no
Right.
problem. They look great. Yeah.
Right. What's your thought on using AI to interpret the time lapse data to determine which embryo to transfer first?
I don't know if they've been able to prove the value of it yet. I'm all for it though. Like, it's just a matter of time and getting the data.
Right.
And I think it's fascinating. They're not just looking at the morphology, they're looking at like the kinetics and how the embryo divided and how long it took. And embryos do weird stuff that I didn't realize until you watch videos of them. I mean, they'll go to 2 cells and then they'll stay quiet for a long time and then suddenly it'll like explode and do a bunch of cell division. Like, well, that doesn't look normal. So I know they're working on training the AI on finding things, which when I asked one of the companies, well, what do you tell it to look at? Well, like, what is it looking at? And they say, we don't know. It's just watching and learning. Like, that sounds like true artificial intelligence. It's trying to learn.
It's creating neural networks. And
So
it just gets smarter and smarter over time.
Yeah, I know they do give you like their grading, and that's something to go off of. I don't know if I've read any like studies on. I'm sure they're saying that it's working. I don't think they're saying it's like.
I mean, there's no robust, high quality studies that have looked into this yet, because I think that's one of the limitations in our field, where I love innovation and I think it's amazing. And the issue with it is that when patients are struggling, they don't want to wait. They don't want to wait to have access to these tools to find out that in 5 years later, there was this really high quality RCT that showed that it's actually extremely beneficial and you could get to baby sooner. And so people want access to these things, but obviously in many cases, because of the cost, it's out of reach. There's a financial barrier. So it does limit our analysis of, should we do this for everybody versus there are a select group of patients who benefit from this. So it's tricky. Yeah.
And selection's kind of the name of the game. That's really what we're doing in IVF, right? We're playing the numbers game. We're going to get a bunch of eggs and see how many fertilize, see how many make it, and then try and pick the best one. We're trying to hone it down. And so, a tool like that's just another selection criteria.
Right. To prioritize which one to transfer first. So the goal is we're not going to actually change the IVF outcome from a singular IVF cycle if you've made embryos. It's a matter of reducing the number of transfers it takes to get to your baby.
We're not making better embryos in time lapse. We're hopefully selecting.
We're prioritizing better.
We're removing this human who's kind of guessing like which ones look the best. And an AI is saying,
yes,
I'm smarter than you.
Okay, so can you briefly walk us through grading of the embryos? So now they've cultured for 5 to 7 days. You take it out, you're looking under the microscope and evaluating these embryos. How do you do it? And how much does grading mean to you as an embryologist?
Ooh, good question. So you asked earlier if we check on day 3. We don't check on day 3 anymore. We used to. We check and we grade and we'd update the patient. And then we got to a point where we're like, there's really no value to this. And we're just taking embryos out and then giving patients information that they're like, what does that mean? Like, I don't know. They're dividing. Nothing.
Hard to say.
We're still going to wait till day 5 to see which ones make it to blastocyst. So grading blastocyst embryos, we're looking at 3 main things. First one's level of expansion. So blastocyst is where they've started to develop that cavity in the middle, and then they're expanding. The cells on the outside, they're stretching the shell, the zona pellucida. So we're assessing what's the level of expansion. Are they fully expanded? Are they expanding? Are they early blastocysts? And then the 2 main things we're looking at are the trophectoderm and the inner cell mass. The trophectoderm are the cells that go around the outside. And then the inner cell mass, the ICM, is what eventually becomes the actual baby. And that's like a clump of cells that are, they all kind of merge together. And it's quite subjective. you're looking at the amount of cells. Do they look fairly uniform to each other? How large is the inner cell mass? Is it nice and chunky? Is it kind of small? Is it really nice and compact together? Can you still see individual cells? And so it's a pretty simple grading system. Labs can be a little bit different, but everyone's pretty similar. We're given an A, B, or C. A is the best and for the trifectorum and the inner cell mass. I think there's value to grading, especially when it comes to the selection. You're going to transfer the best graded ones first. I have wondered what is the value of the actual grade for the lab and for the patient. Because we're trying to standardize how we grade our embryos, especially within our lab. But what value is it to a patient to kind of compare their grade to other patients? Because we're always going to transfer best looking ones. Could it be like detrimental if a patient's best graded embryo is a BC? When, she thinks, oh, if I don't have an AA, my chance goes way down. Now you have, is there a psychological impact to their
to knowing outcome? The grade.
Yeah, versus what if we just of ranked them 1 through 5. Number 1 is your best one, and then we'll do number 2.
I like that.
Right?
I actually like that so much more. I mean, and it's really funny. I've had a handful of patients where we transfer the best ones, they don't work, and then all they're left with is a day 7 that's poorly graded. Yeah. And I'm sitting here thinking like, oh man, this, I'm going to have to really talk to them about doing another IVF cycle soon. Manage expectations. I even offer do you want to just do another cycle from now? And then we go to transfer and then boom, they're pregnant and they graduate. And you're like, well, okay. So, and this always makes me a little bit torn because maybe if you checked an hour later, would it have a different grade? The timing of the day.
Yeah. Or day 5 versus day 6, a day 5 BB. If I let that go to day 6, it's probably gonna be an AA tomorrow. Right. So why are you stressed out that it's a BB today? It's probably better because our day 5s tend to perform a little bit better than our day 6s. So yeah, grading. Wow. Yeah, I don't want patients to put too much weight on it. Yeah. We always say if an embryologist froze it, that means it met the criteria for freezing and it's got a good chance of success. I like that. Trust that. Yeah. You got a good chance.
Yeah, it's true. So now PGT versus not is a whole different topic, but in order to do genetic testing of the embryos, there's a couple things you have to do, right? So can you walk us through how you get to the cells, how you're biopsying, how invasive it is versus not?
Biopsying a blastocyst embryo is probably the most sci-fi thing that we do in the lab, I feel like, because we're using a laser. It's the big fancy microscope that we're working on. Same thing, joysticks and suction. What we're trying to do is remove about 5 cells from the trifectoderm. So you're trying to orient the embryo in a way that you're not going to affect the inner cell mass. You don't want to hit that with a laser, but there's different objectives on a microscope. When you rotate and then it jumps up in magnification. Well, there's one really fancy, really expensive objective that has a laser on it. So you can see what you're doing, but there's also a laser that's aligned and there's a little foot pedal that when you push the pedal, it fires this laser for a microburst for microseconds. And that laser puts off heat. And so when you point it at some cell junctions and you press the button on the floor, that laser fires and that heat makes a cut in between those cells. So you're playing the video game of suction, holding onto some cells that you got to make a hole in the shell in the zona with the laser so you can have access. So you're making a hole, then you're pushing a little pipette in there, using suction, grabbing some cells. There's videos out there. I've put videos out there.
Yeah. They're fun. They're fun videos.
Tread lightly because some people see that and they're like, you're being so mean to that embryo. And it looks pretty aggressive, barbaric almost, but somehow they do really well with it. Yeah, and it's safe. It's amazing.
Yeah.
Embryos
are pretty resilient.
Yeah, they'll collapse when you do that. And then you go to freeze them 30 minutes later and they're already re-expanding. Like they bounce back. Yeah. So using that laser, take a couple cells, and then we put those small cells into a really small tube, and that's what we send off to the labs that do the PGT testing on them.
Yeah. All right. So I'm loving all the step-by-step that we've gone through, getting all the way to embryo. But I know that there's a lot of people who want to know various IVF lab add-ons. Are they worth it? A lot of times the biggest reason for questioning these add-ons is it going to benefit me? Is it worth the money? Is it worth the hype? So just sort of rapid fire. Let's go through each thing and see your thought on whether and in what scenario patients should consider these add-ons. Okay, let's start with calcium ionophore.
Ooh, yeah, that's good science backing that up. But we do it on patients who have had like failed fertilization or really low fertilization. Like there's something going on with the eggs and they need the extra calcium ionophore. In our lab, that's how we do it. Yeah.
Okay, love that. What about Pixie?
It was something that seemed really promising historically, and then we got big data and it didn't really deliver. It still sounds like a good idea, but I think most people have moved away from using it. We don't use it at all.
Yeah. Same. Unless it's requested specifically.
Yeah, it gets requested sometimes and we still try and talk them out of it. Because it's like, we don't ever do this. Like, if anything, you're probably gonna get like a worse ICSI because we're not good at it.
Yeah. And then embryo glue is a big one.
We offer it. We don't do it on all patients yet. I think the data have shown it's good for some patients, but for who, how do you know? It's not going to be bad. So maybe it's a good idea.
Yeah, that's it. That's usually the take I have. It's probably not going to harm. If you want to add it on, go for it. Yeah. What would you say is an embryology or IVF add-on that sounds exciting, but has really no scientific evidence to back it?
Oh, I feel like I'm going to think of something after.
It always happens like that.
That sounds exciting. Maybe where we're starting to get into like whole genome amplification with PGT.
Oh, you're getting controversial. I like it. Just right at the end. Well, gonna have to bring you back.
We've had some patients recently that have requested. They're like, we tend to have a bit of a younger patient population in Utah, and so we've had like 29-year-olds request to do this like extra testing of like, well, maybe there's a de novo mutation in one of my embryos. It's
Got
like,
it.
Yeah, maybe like. It's like $1,500 per embryo or something.
At least.
So expensive.
Yeah,
so
it is. It's very costly.
I mean, if you make that kind of money, sure. There's also the what do they call it? Like the sibling testing. So if you biopsy, say 5 embryos for a patient, they can pay to double check that they're all related to each other, like as if for somehow
that there was no lab error.
Yeah, like
interesting.
I get it. I get it. Peace of mind, but like also I don't just have like 3 different patients' embryos and I'm just trying to keep track. Like that's pretty low. Like we're very careful with that.
Yes.
So that's becoming, I think, more popular. You know, that once we have the technology, it's like, hey, if you want it, we can make sure you're related to these embryos and they're all related to each other.
Yeah. Now on a scale of 1 to 10, how important is the embryology lab?
I think I used to think it was lower, but the longer I do it and the more we look at things and make adjustments and then you see the impact, like, ooh, we're pretty important.
High out there.
Pretty important. 8, 9.
8, 9, 10.
10. I think there's, I think I'd be interested to see in the future the things that we learn of things that patients can do. Like I said, because we can't change their biology. So things that patients can do. One thing I like, just a side note, like with Zymot trying to avoid DNA fragmentation, there's been studies that show significantly lower periods of ejaculatory abstinence lowers DNA fragmentation. So that's free. Just come in with a few hours of abstinence versus 3 days.
I often say that too. Yeah. Okay, amazing. Well, thanks for joining me today, Shaun. And where can everyone find you?
Mostly on Instagram,
Okay.
Shaun.ology, I believe is.
Yes.
Yeah.
All right. Well, thanks for being on the
Yeah,
podcast.
thanks for having me.